Hello guys, welcome back to Medico DIY, and today in this video we'll be talking about Guillain-Barré Syndrome. Guillain-Barré Syndrome, it is an immune-mediated acute demyelinating disease of the peripheral nervous system which is characterized by acute flaccid paralysis which evolves over days or weeks with loss of tendon reflexes. It is one of the most common cause of neuromuscular paralysis worldwide. Talking about the types of Guillain-Barré Syndrome, there are mainly four types, that is acute motor axonal neuropathy, acute motor sensory axonal neuropathy, acute inflammatory demyelinating polyneuropathy, and Miller-Fisher syndrome. Among these, the third one, that is acute inflammatory demyelinating polyneuropathy, it is the most common variant. Talking about the pathophysiology, in most cases GBS follows a viral infection or a vaccination or even a surgery, while in others, no prodrome is identified. The infection can be in the form of upper respiratory tract infections or even the gastrointestinal infection. The infection generates an autoimmune response where the antibodies are formed against the organism, which cross-reacts with the myelin sheath or axon component of the nerves, causing demyelination, and hence results in the clinical features. Talking about the clinical features, it can occur at any age, including the pediatric population, and the incidence of the disease is 1 to 2 per 1 lakh population per year. And the most common characteristic features of the Guillain-Barré syndrome is that it is characterized by progressive symmetric ascending flaccid paralysis, and it develops over hours to weeks, up to 2 weeks, or maximum the symptoms can develop up to 4 weeks. And the paralysis is ascending type of paralysis, and it ascends from the lower to the upper limbs and is more marked proximally than distally. The distal paresthesia and pain precedes the muscle weakness. The earliest manifestation is the distal areflexia. The reflexes are either hyperactive or even absent. In 70% of the patients, they also develop facial or oropharyngeal weakness. The respiratory muscle weakness results in respiratory failure, and the respiratory failure is type 2, and the respiratory failure can develop within hours. The patient may also develop the bladder dysfunction in the late case or in severe cases. The most common symptom in pediatric population is the pain. The pain presents in the hip, back, or thigh. There is also cranial nerve involvement. Most common nerves involvement is cranial nerve 7, 9, 10, 11, and 12. The motor involvement is predominant while the sensory involvement is minimal. The sensory symptoms are in the form of paresthesia in the hands and feet. There is also autonomic instability, which is potentially life-threatening, and the autonomic instability presents in the form of tachycardia, bradycardia, hypertension, or hypertension. On examination, we can find that there is diffuse weakness with loss of reflexes. In Miller-Fisher syndrome, it presents with internal and external ophthalmoplegia, ataxia, and areflexia. And the sequel is presents at 3 months, in which there is symmetric atrophy of the distal muscles. Talking about the methods of diagnosis, the diagnosis can be done by CSF study, that is cerebrospinal fluid study, nerve conduction study, electromyography, and MRI. In MRI, we can see that there is demyelination. And in the serum, we can also see that there is antibodies to the ganglioside GM1 found in about 25% of the cases, and usually the axonal form. Talking about the CSF study, the most characteristic feature is the cytoalbuminic dissociation. The CSF protein is raised but may be normal in the first 10 days, and usually there is no increase in the CSF white cell count. But if the white cell count is more than 10 into 10 to the power of 6 cells per liter, it suggests an alternative diagnosis. Talking about the alternative diagnosis, it can be poliomyelitis, botulism, diphtheria, spinal cord syndromes, or myasthenia. And this differential diagnosis can be differentiated with the help of history and examination. Now let's talk about the treatment. Talking about the treatment is in the form of IV immunoglobulin or plasmapheresis or both. If the patient presents early, then the treatment is in the form of high dose of intravenous immunoglobulin. The dose is 0.4 gram per kg daily infusion for 5 days, and this immunoglobulin, it neutralizes the GBS autoantibodies, and it should be given within 2 weeks of the first motor symptoms. And if the patient has IgA deficiency, then it may develop allergic reactions. Hence, the patient should be screened for IgA deficiency. And if the patient presents late, that is usually after 2 weeks, then plasmapheresis is done, and it is done at 40 to 50 ml per kg 4 times a week. And in severe cases, both IV immunoglobulin plus plasmapheresis is given. Along with these treatment, the patient also needs supportive measures like monitoring in the ICU, maintenance of the airway and breathing, ventilatory support in case of respiratory failure, and the patient should also be given the DVT prophylaxis, that is deep venous thrombosis prophylaxis. Tracheostomy may also be needed, physiotherapy, and daily reassurances. Hence, this much for today. Hope you enjoyed the video, and if you want to know about any other topics, let me know in the comment section below, and stay tuned for more videos. Thank you.